Dr. Rohan for his free paper, Functional and Psychological Impact of Ethambutol-Induced Toxic Optic Neuropathy.
A very good afternoon. Today I'll be presenting the paper titled Functional and Psychological Impact of Ethambutol-Induced Toxic Optic Neuropathy. So tuberculosis is a pandemic affecting around 10 million people annually, and ethambutol is a commonly used first-line anti-tubercular agent. However, it can cause dose-dependent optic nerve toxicity, which fortunately for most patients is recoverable. However, the psychological and functional impact of said toxicity has not been evaluated in detail. So for the purpose of the same, we conducted a prospective observational cross-sectional study over a period of 18 months after approval by the Institutional Ethics Committee. We studied patients newly diagnosed with ethambutol-induced toxic optic neuropathy based on specialist examination and aided by investigations as and where necessary. To To exclude the effect of confounders, we excluded patients who had visually significant cataracts, corneal or macular pathologies, glaucoma, physical disabilities limiting day-to-day activity, neurological deficits, cardiorespiratory status affecting ambulation, or psychiatric disorders. So consenting patients who fulfill the study criteria were analyzed for age, sex, duration of anti-tubercular therapy, BCVA at presentation, time between initiation of ATT and onset of vision loss, time between vision loss and presentation for care, and psychofunctional assessment was done with the Indian Vision Function Questionnaire, which is a 33-point questionnaire and has questions graded on a Likert scale, in which higher score correlates to worse function and more distress. It is further subdivided into 3 subscales, being the general function or VFI-GF subscale, vision-related psychological distress subscale or the VFI-PV subscale, and the psychosocial distress or VFI-PG subscale. So we had a total of 20 patients who presented with bilateral asymmetric vision loss and were on ATT for about 7 months. The average duration of ATT before vision loss was 5.5 months, and the lag between vision loss and presentation to care was a month and a half. All of them had reasonable afflictions towards general function, vision-related psychological distress, as well as psychosocial distress. Worsening BCVA, whether it be mean BCVA or BCVA in the better eye or BCVA in the worse eye, correlated significantly with worsening of general function for all patients. Drop in BCVA to worse than 0.3 logMAR units causes significant drop in general function as well as vision-related psychological distress. So a longer duration of ATT before onset of vision loss correlated significantly with worse BCVA and therefore worse general function on presentation, and a longer duration of vision loss before presentation correlated with worse psychological general social distress and vision-related psychological distress on presentation. So ethambutol, as we know, causes a dose-dependent toxicity, with the risk of which increases with longer duration of treatment and dosages more than 15 mg per kg per day. And 50% of patients may have subclinical ethambutol-induced toxic optic neuropathy after 6 months of therapy, regardless of symptoms. The vision loss can handicap their general function and affect their mental health, resulting in worse health-related quality of life. Prolonged vision loss can worsen these effects further. It has been shown in earlier studies that patients may be willing to trade up to half of their remaining lifespans for regaining vision, so these things need to be taken seriously. So the mainstay of treatment is early diagnosis and cessation of ethambutol, following which patients may recover or have persistent low vision. If in case the vision does not improve for said patient, we can always have the option of going for low vision aids and thorough counseling. Awareness of low vision services to increase the uptake of the same, perceptual training and environmental modification can further help improve their quality of life. So to conclude, ethambutol-induced toxic optic neuropathy causes significant vision loss and psychofunctional disturbance. Worse BCVA causes worsening of general function. BCVA worse than 0.3 logMAR units causes significantly more psychological distress. Screening, early diagnosis and cessation of ethambutol are crucial. Counseling and low vision aids may be used for the treatment of patients on a case-by-case basis, and more effort may be laid towards patients with worse BCVA on presentation. Thank you.
Thank you, Dr. Rohan. You did not have any control group where you compared these scores?
No, sir.
The question why I asked this was that how are you labeling this as the quality of life affected because of ethambutol. It would be the same. I mean, why would the scores be different if the vision loss was due to some other cause?
So it could be, definitely could be. However, since we have excluded all other causes of vision loss in the
No,
patient.
no, no. I didn't mean that the vision loss in this patient is clearly ethambutol related. What I meant to say was that to say that this distress is related to ethambutol is not there. So, I mean, I would rather say that this is just a quality of life questionnaire which is showing distress in patients who have subnormal vision rather than ethambutol toxicity. You've clustered a group of patients who are ethambutol toxicity related vision loss. I can cluster a group of patients who were, post-tumor, whatever, pituitary macroadenoma vision loss, and the VFQ scores would have been similar. What I wanted to say was that if I'm just giving you, if you had a comparison with some other acute or chronic disorder, maybe you would have picked out something more that this is more specific for ethambutol as compared to that was my question.
Correct.
point well
Exactly what I thought also. You could have taken overall diminution of vision as one side and only those because of ethambutol. Then you may have whether this is above the average or below the average, which rather than talking about the treatment aspects, that will be a better thing. Just a suggestion. Thank you.
Thank you, sir.
So these were
Any-
these
yeah,
patients were
just-
this was vision loss was self-reported, and
Yes,
then
yes.
they presented to care on their own later, is it?
Yes, sir. All self-reported, sir.
So we don't know that they probably came to self-reporting only when it got severe already.
Yes, sir.
So I think that's another important factor to put in,
Yes, sir.
because self-reporting patients will always report later than if you pick it up clinically.
Definitely, sir. Thank you.
Thank you.